Hello, step 2, CK. Resume. This is a comprehensive reading for CK step 2 USMLE. So we have a patient is a female, 62 years old. She have a lesion on her skin. Which of the following is the most appropriate next step in the management of this patient's forearm lesion? So the answer is excision biopsy. Excision biopsy. So we had to do a excision biopsy because she's having a melanoma. So learning about melanoma, visual assessment of the melanoma. So we can use the ABCDE criteria. ABCDE criteria is ABCDE. A, asymmetrical. B, border irregularity. C, color variation. D, diameter more than 6 millimeter. E, involving appearance over time. The last one is involving appearance over time. It's like a change in the appearance. So asymmetrical, border irregularity, color variation with the lesion of compared to other lesions, diameter more than 6 millimeter, involving appearance over time. So this is ABCDE criteria. Is if you have more than two, or more than one or two, is suspicious of melanoma. So you can use another criteria too. You can use the 7-point checklist. You have two type of criteria for this one: major criteria, minor criteria. Major criteria is change in size, shape, or color. Or minor criteria is if the size is more than 7 millimeters, local inflammation, crushing or bleeding, or sensory symptoms. If you have one major criteria or more than 3 minor criteria, is suspicious too. The last one criteria you can check for a melanoma is the ugly duckling sign. The ugly duckling sign is mean one lesion is significantly different from others in the patients. By example, you have a patient that have multiple lesions because he have been all the time exposed to the sunlight, but in between all this lesion that you can see in that patient, there's one that is look different. This is the ugly duckling sign. So the ugly duckling sign describes the nevus that is obviously different from the others in a given individual. This term is used to intra-patient comparative analysis, like they compare a lot of patients with navel, and widely recognized is a major indicator of suspicion of melanoma, both visually and dermatologically. So it's look like this. So you have a lot of different lesions, but one look different. The ugly duckling. You can see here. Ooh. You can spot a melanoma there. So the ugly duckling sign. The ugly duckling sign. So the ugly duckling sign, remember the treatment for this is excisional biopsy. So the ABCDE criteria are useful in visual inspection of pigmental skin lesion to identify which may be represent a malignant melanoma. However, through the ABCDE criteria, you can assist in evaluation of superficial pregnant melanoma. They are less effective they are less effective in other kind of type of melanomas. So the nodulous melanomas account for 30% of all melanoma, but may not meet any of the criteria of the ABCDE criteria until they are realized in advance. They're big. So this is the ABCDE is not for the all kind of melanomas. There's some kind of melanoma that you can know only you can see in the 30% of those kind of melanoma with that checklist. So to address this kind of melanoma, additional visual criteria should be considered in associated risk of melanoma. So in this case of these patients with multiple pigmented lesions, a lesion that is substantially different from others but in shape and color may represent a melanoma, the ugly duckling sign. The ugly duckling sign has a sensitivity of 90% of melanoma, 90% for a melanoma. So with the criteria of the ugly duckling sign, the ugly duckling sign has a sensitivity of up to 90% for melanoma. So palpable nodulo often correspond to the vertical growth of the melanoma and increased melanoma risk too. So you can use that two criteria, the ugly duckling sign and palpable. You can palpable the melanoma, and you can palpable like a nodulo. You can feel like a nodularity, like you can feel like a nodulo that is going deeper. So you can use the Breslow dip. This is the distance from the epidermal granular cell layer to the deepest possible melanoma cell. It is the most important prognostic for an indicator of malignancy in melanoma. So this is, I have seen that in different questions too. So they describe you a melanoma and they ask you, what is the most important prognostic indicator for this kind of melanoma, if it is malignancy or not? It is like the answer is the Breslow deep, or the distance, how deep is the melanoma. This is the answer. So this is I have seen that questions in before, like what is the more significant malignancy, who tell you like there's malignancy, who tell you what is the most important sign of malignancy, and really is the Breslow deep, or how deep is the melanoma. So the Breslow thickness is the measurement of the depth of the melanoma from the surface of the skin down through the deepest point of the tumor. So you can see here, you have the normal skin, you have a melanoma here going deeper and deeper and deeper and deeper. This describes the malignancy. How this describes the prognostic, or if you can have metastasis. So the benign pigmented lesions are usually asymptomatic. So biopsy should be considered in moles that itch, bleed, or are associated with a local sensory symptoms. By example, you have a molar, but the molar you never feel anything, but one day you feel like the molar is itching or is bleeding. If it would be a normal molar, you never feel anything, but if it is a melanoma, you start feeling itching or bleeding, you have to make a biopsy. So a mole may represent a melanoma if it appears substantially different from others, the ugly duckling sign. If it is itch or bleed, or develop nodularity, like you feel a nodule under there. If melanoma is suspected, an excision biopsy should be obtained. Next. So the next question is a boy. He come with his mom to the office. He's 19 years old. He come because his mom looked like he had been poor performance or changed behavior. So he haven't changed anything in the appetite or sleeping, and his mother is concerned because he probably he need antidepressive or something. He think he's depressed. He's usually talkative, but in the interview he don't want to talk. So, which of the following is the most appropriate next step in the management? So the correct answer is evaluate the patient without his mother being in the room. Evaluate the patient without his mother being in the room. That's the following most appropriate next step. So, when patients have difficulty providing history to themselves, obtaining collateral information from family member is important. However, all patients, including vulnerable adults, children, and elderly, should be given the opportunity to speak with their physicians alone and tell their stories of their own words. So they usually, especially when they're young patient, they feel uncomfortable answering certain questions in front of their family member. This is especially true of questions regarding mental health, including suicidal thought, drug use, sexual history, and domestic violence. If you allow the patient to talk alone with the doctor, this may help clarify his concern. That can develop a little rapport and establish a more effective treatment plan. So patients may be reluctant to discuss sensitive issues in the presence of family member. All patients of all age and functional levels should be given the opportunity to meet with their physicians by alone. So the next question is about a lady, 45 woman. She's having hand and wrist pain. She was on a trip out of the state. He was on a slot machine. He was pulling the slot machine for a long time, probably. And now she's having pain. Get worse when she opens some kind of a jar or some container. So, when she moved her wrist lateral, when she lifts something, the pain get worse. So the question say, which of the is the most appropriate next step in this patient? So the answer is no additional testing. Some people pick MRI, some other pick X-ray in the hands and the wrist. So the right answer exactly is no additional testing. So why no additional testing? Because these patients are having the Quervain tendinopathy. Can be also known like the Quervain syndrome, the Quervain tendinopathy, or the Quervain tendinitis. It's like you have an inflammation of the extensor radicular. You have this tendon here. You get inflamed. So if you have like a overuse, yeah, the swelling tendon shield, the thing that cover the tendons here, get inflamed. So this tendon have a name. So the name of this tendon is the pollicis brevis tendon, the extensor pollicis brevis, and the abductor pollicis longus tendon. They both go through here, this shield here, and this get inflamed. So how you test this? You do this, the Franklin test, the Finkelstein test. So you ask the patient to keep your hand straight, put your thumb inside your palm, and then you cross you bend your fingers like you're making a fist, and then you bend your wrist toward down to the pinky finger. You bend it down. If you are having pain at that moment, this is a positive Finkelstein test. If you have pain in this area here, when you turn your down, when you bend your wrist toward the finger down, that's the positive Finkelstein test. So the Quervain oh goodness, the Quervain tendinopathy or tenosynovitis. There's something called tenosynovitis. We have to read about that one. There's a different one. But the Quervain tendinopathy is the pathogenesis is a myxoid degeneration of the tendon shields, the one I showed you before. So in both abductor pollicis longus and extensor pollicis brevis. Okay, those are the tendons that pull the thumb up or back. The symptoms are lateral hand wrist pain, provoked by lifting object, thumb or wrist movement. The diagnosis is made of clinical features. For example, positive provocative testing, the test that we talked before. So tenderness when you touch the radial area, styloid. Pain and thumb flexion. Pain with thumb flexion plus ulnar wrist deviation. The management is a thumb spica splint, like the Velcro one that you get from the pharmacy, non-steroid anti-inflammatory drugs, and persistent severe cases you have to use corticosteroids injections. So the question said, what other tests you do? Any other test, just analgesics. So these patients have a Quervain tenosynovitis, no, the Quervain tendinopathy. So correction, the Quervain tendinopathy, Quervain tenosynovitis is the same pathology. So the Quervain tenosynovitis or Querban tendinopathy is an overuse syndrome involving the tendon of the abductor pollicis longus and extensor pollicis brevis. It typically presents lateral hands and wrist pain, often aggravated by resisted thumb adduction or extension, by example, lifting a baby under the arms, or forceful radial ulnar deviation, by example, the test that we talked before, or opening a jar or something, working tool with the hands. So the diagnosis of the tenosynovitis, the Querban or Querban tenosynovitis or Querban tendinopathy is based on clinical features. Examination typically show tenderness at the radial styloids and lateral wrist at the base of the hand. In addition, the pain can be produced with provocative measures like that stretch the affected tendons by flexing the thumb with the wrist in ulnar deviation. That's called the Finkelstein or H-Snuff test. H-Snuff test. Finkelstein and H-Snuff test. In such a case, no additional testing, like this is the answer of this question, no additional testing is needed. Thank you. Next question. So the next question is about a lady, 32 years woman. So she's gravid at 1, but at 0. She's in the 42 weeks of gestation, and she's having contraction. She have a rupture of membrane and contractions. She have a spontaneous rupture of membrane and contraction. She's delivering. But she's only 4 centimeters, and the baby is having suffer. The baby heart rate is 130. 130 per minute, and they ask her, okay, let's do the cesarean delivery, and she refused. So which of the following is the most appropriate next step? The answer is respect the patient's decision and proceed with vaginal delivery. Even if not the best interest for the baby, the mother has still the last word. So the pregnant woman with capacity have the same right to refuse treatment, emergency cesarean delivery, by example, as the non-pregnant patient, even if the decision does not represent the best interest for the fetus. So even a pregnant woman have the same right of no pregnant woman. So if they decide not to have a cesarean, they will have to make the decision with her. Like this labor patient has a capacity 3 fetal heart, has a category 3 fetal heart rate tracing, by example, absent variability, recurrent late deceleration, and sign of fetal hypoxemia. That is, if it is sustained, it may lead to the fetal dismiss, so the baby can die. So patients with category 3 fetal heart rate tracing are typically managed with emergency cesarean delivery. Okay, so patients have the right to make their own medical decision as long as they understand the risks and benefits of the procedure. For example, have capacity. The patient understand that baby could die. The patient have to understand that. So if she still decide not to do the cesarean delivery, it's okay for the doctor doesn't have to convince her. Such decisions can become more complicated in the setting of pregnant women, as both of mother and fetus are affected. So, however, until delivery, the mother has complete autonomy for medical decisions affecting both herself and the fetus. So, included refusal of treatment, even if it leads to adverse fetal outcomes. Including refusal of the treatment, even if this leads to adverse fetal outcomes. In those scenarios, the right of the mother are considered over those of the fetus. Therefore, the most appropriate next step in this case is to respect the patient's decision and continue with vaginal delivery. Respect the patient's decision and proceed with vaginal delivery. That's the answer. Next. So the next question is a lady, pregnant woman, gravid at 3 with But at she's in 31 with the gestation. She can't because she cannot feel the baby. When they do the ultrasound, they find out the baby is fetal dismiss. So the baby died. So they do the vaginal delivery, and she asking, what can I do for my next baby? This does not happen again. So the correct answer is, though this is a hard decision, a fetal autopsy and a placental evaluation may help us to assess the future first for more clearly. So the answer is, so to do autopsy and a placental evaluation to help to assess what could be what probably was the cause of this dismiss. So stillbirth or intrauterine fetal demise refers to the fetal death at the age of more than 20 weeks of gestation occurring prior to delivery. So patients with previous stillbirth are 2 to 10 times more likely to have another. However, the exact risk for the recurrence of appropriated prevention strategies. However, the exact risk for recurrence and appropriated prevention strategies indicated during the future pregnancy will depend on the underlying cause of the first stillbirth. So that's why we have to do the biopsy of the placental evaluation and fetal autopsy. So the pathophysiology of the stillbirth can be fetal, placental, or maternal in origin. Two of the highest yield tests for identifying the cause of the placental evaluation and fetal autopsy. This is the most high yield test that you can do for find out why this stillbirth is happening. So you have to do a placental evaluation and a fetal autopsy. You have to do gross and microscope placental evaluation to reveal evidences of placental thrombosis, eruption, infection, or other placental disease. So fetal autopsy can be estimated at the time of the death. So the fetal autopsy can estimate the time of the death, identify if there's an anatomic abnormalities, and facilitate additional genetic studies. Patients who decline the fetal autopsy are still recommended to undergo non-invasive fetal evaluation, by example, external examination for dysmorphic features on MRI, and evaluation of placenta, fetal membranes, and umbilical cord. In addition, maternal testing for other causes of stillbirth, by example, antiphospholipid antibody syndrome, and fetal maternal hemorrhage should be performed. However, even other thoughts evaluation of the health of the stillborn have no identifiable cause. So the most important things to do when you have a stillbirth is to trying to convince the parents to do a placental evaluation or a fetal autopsy. So identifying the cause of the stillbirth, including the fetal dismiss, help to determine the risk of recurrence and prevent the strategies for the future pregnancies. So evaluation should include fetal autopsy, genetic testing, placental examination, and maternal testing. So this is the last question. Is about a patient. She's a woman. She has 56 years old. She comes to the office because I have a skin lesion in the right arm. It's red, and she noticed it 4 weeks ago. And she had history of breast cancer 7 years ago. She had treatment and radiation and chemotherapy on that side. The left side looked okay. So which of is the best next step in the management of this patient? So what you do? The answer is lesion the biopsy. Lesion the biopsy. So we will think that it could be like an infection. Other options are antifungical, antibiotics, reassure the patient on observation on topical corticoids. But no, the answer is lesion biopsy. Do a biopsy of the lesion. So in this case, this patient was treated for breast cancer 7 years ago and now has a rapidly progressive pulpal skin lesion with indistinct borders, indicating like angiosarcoma. So these patients are having an angiosarcoma. An angiosarcoma is a rare malignant tumor delivered from vascular endothelial cells. Though the risk of primary breast angiosarcoma is quite low, patients with breast cancer who undergo radiotherapy and axillary lymph node dissection are at a subsequently increased risk of secondary angiosarcoma, approximately 4 to 8 years after therapy. Okay, so when you have a patient that it went into the radiotherapy and chemotherapy, 4 or 8 years later, you can have an angiosarcoma. So secondary angiosarcoma typically present with purple papulonodular lesions and red bruise-like plaquelet on the breast, axilla, and upper arm. Because the tumor spread with a vasculature, most likely have indistinct borders. So the diagnosis is confirmed by biopsy. Secondary angiosarcoma is an aggressive tumor that rapidly metastasizes. It's rare to metastasize, but however, early surgical resection can often be curative. So you can do a resection of the area. Okay, so learn that this is a angiosarcoma after chemotherapy. So thank you very much, guys. We keep talking about this. Be sure to subscribe and hit the like button. Thank you very much, guys. Keep studying hard.